Let's talk a little bit about the evaluation of a patient presenting with a vascular event. In the ED, we often start with a non-contrast head CT to rule out intracranial hemorrhage, especially if we're considering treatment with IV TPA. However, strokes don't show up on CT for 6 to 12 hours and can be missed if they're small, so we actually prefer MRI. Acute ischemia shows up as bright on diffusion-weighted imaging after only a few minutes. It takes about 4 to 6 hours to show up on flare. The MRI can also identify something that we call the ischemic penumbra. Diffusion-weighted MRI shows the infarcted core of the stroke, the area that's already dead, but perfusion imaging shows area that's at higher risk, or the ischemic penumbra, which is potentially salvageable with either recanalization due to IV or intraarterial TPA or other treatments. The workup for vascular events takes into account the different possible etiologies, most notably cardiac embolus, carotid or vertebrobasilar artery-to-artery embolization, large artery, example MCA stenosis, or small vessel disease. Laboratory evaluations useful for identification of modifiable risk factors, specifically the LDL and hemoglobin A1C. There's some data that suggests that high-sensitivity CRP is actually a great marker of overall vascular disease burden, which can also be useful. I tend to reserve the hypercoagulable workup for the atypical patient, particularly the young, in whom another etiology for their stroke has not been found. It's expensive, and common things being common, it's likely one of these other factors. Only the arterial workup should be sent unless they have a PFO. Everyone should have an echocardiogram to evaluate for poor ejection fraction or structural abnormalities or clot if there's been evidence of atrial fibrillation on telemetry or they have a history. A TTE is perfectly adequate in the majority of patients, but it doesn't show the aortic arch or the atrial appendage as well as TEE. So if your suspicion is high for a cardioembolic source, for example, the patient has AFib, which is often seen more commonly in older patients with enlarged atria, or arch disease, you may consider it. As I was saying, atrial fibrillation is not uncommon in older patients and not uncommon as a cause of stroke. All patients are placed on telemetry when they arrive in the hospital. There is also some data that shows that 30-day event monitors are more effective than short-term Holter monitoring at picking up paroxysmal atrial fibrillation. So in someone that I think is high risk, for example, their stroke appears cardioembolic on MRI, like a wedge-shaped, or they're older with structural heart disease or enlarged atria, a 30-day event monitor is something I consider. This is because it's important to pick up AFib strokes because they're treated differently with a blood thinner such as Coumadin or one of the new oral anticoagulants. It's also important because AFib clots tend to be big and result in large vessel strokes, which are more disabling and fatal. Besides looking at the heart, we also want to look at the neck, either the carotids or the vertebrobasilar system, depending on the distribution of the stroke. A carotid duplex is a cheap and efficient way to do this without exposing the patient to any dye load, though it doesn't allow visualization of the more distal carotid or the vertebrobasilar system, the way that a CTA and MRA of the head and neck do. I like CTAs the best, as MRAs are flow-based and can overcall stenoses. But everyone will have a bias, and MRAs are perfectly fine. One of the classic MRI findings for carotid disease is this string of pearls distribution on diffusion, which is caused by a shower of small emboli from the carotid plaque that lodge distally in the small vessels that make up the border zone. It's important to know that stroke is common and leads to significant morbidity and mortality. IV TPA is currently the best treatment we have for patients presenting within the 3 to 4.5 hour window. And remember that time is brain, but also always remember you have your chief.